Good afternoon, folks. Hope that you enjoyed a good lunch. Hope you did some good networking. Tiny bit of housekeeping, and I'm trying to break up the housekeeping in between these sessions so you don't get a huge information download. You might find some forms on your seats in the coming sessions. These are feedback forms. We genuinely want to have some feedback on the sessions that you're attending, whether it's constructive criticism or praise or suggestions going forwards. So please don't be shy. You can also use the app, details of which you can still find on the back of your badges, to say what you've enjoyed. Tell us what you'd like to see going forwards. If you've not been in this room before, this is the Plaza. This is Stream 2. Coming up in this room at 3:30 is ophthalmology. But this session is investing in emerging markets, and it's chaired by HBO's very own Lee Murray. Lee, the floor is yours.
Thank you, David. Good afternoon, everybody. As David mentioned, welcome to this session. Welcome to Investing in Emerging Markets. Hi, Charles. Hi, Max. Welcome. So it'll be no surprise, obviously, to anybody in the room that the pandemic has been causing some challenges the past couple of years, not least within emerging markets, who in particular are at the moment prone to sort of being kept a little bit further behind by the sort of unequal access to vaccination programs. Today, our panel will share our thoughts of exactly where they think the opportunities lie when investing in emerging markets, how business models are changing, how digital health is being adopted and where it still needs to go, and exactly what is happening with the ability to increase access to care through a general rise in insurance generally, particularly in social health insurance, which is presenting a huge opportunity. They'll also discuss a lot of the challenges, particularly to do with things like workforce and the issues that medical tourism brings up. So to introduce our panel, I will start with the gentleman joining me from abroad. So Charles Dalton is a senior health specialist at the IFC. The IFC, as everybody knows, is one of the largest investors in emerging markets. It has over $2 billion in assets in its portfolio. Charles has a global perspective and has spent the last sort of 30 years traveling the world looking at healthcare. Clearly not so much this year as he joins us from Washington. Welcome, Charles. Next up, we have Massimiliano Colella. He's the CEO of Evercare Group. So Evercare is backed by the RISE Fund and TPG, operates 30 hospitals, 16 clinics, and 82 diagnostic centers across Africa and South Asia. It's an impact-led group with a double bottom line, meaning it not only seeks to make a profit, but to balance that with a positive social impact. So welcome, Max. Max, you're joining us from Dubai, is that correct? Welcome.
Thank you. Thanks.
And in the room with us, we have Leandro Cuccioli. He's the head of Consumer and Industrials at CDC, which is the UK's development finance organisation. Again, a bit like Max, he has a focus on South Asia and Africa in particular. Leandro spent 20 years investing in emerging markets, and he's also held senior cabinet positions in the Argentinian government in a bit of his background. Welcome, Leandro. Thanks for joining us.
Thank you, Lee.
So, Charles, you've put a little presentation together. You're going to kick us off, so I'll hand over to you, if that's all right. Thank you, Charles.
Thank you very much. Thank you. Next slide, please. Okay, I've got somebody helping me because last time I managed to break the button. So thank you very much for this opportunity to present. I'm going to keep this very short so we can get on to the main discussion. I'm just going to walk you through some of the worldwide trends that we see from an IFC perspective in emerging markets. Next slide, please. So I'm really going to start by saying that COVID has taught us that there's no one health system has got it right through this very difficult COVID period. And I think looking forward, there's a realization from multiple perspectives that we need to look at how we can strengthen healthcare systems, how perhaps we can remove some of the silos that exist in many of these healthcare systems. There's definitely a need to improve coordination, and there's definitely a move towards getting better value out of the service provision. But very clearly to us, there is increased opportunity for the private sector with the right business models, and I'll explain that as I come onto the next slide. So, definitely increased opportunity, but we are seeing different initiatives in different markets. What's also very clear, there's a need for better planning going forward. There's a need for better data analytics going forward. So the purchaser provider relationships, for example, need to improve. There's definitely realistic growth expectations, but also there's equally opportunity for partnerships. And by partnerships, I don't just mean public-private partnerships. There's also partnerships for the private sector to work together collaboratively in many different countries and across regions. The gap between demand and supply is so big in many of these markets that the public sector isn't going to be able to address many of these issues on their own, and they're going to need the private sector to step in, step up, and expand their service offering, although it's not easy. Okay, next slide, please. So just really looking at the common the sort of the common trends that we see, and I'll start in the middle, and really what's going to happen in the next decade, and building from what was beginning to shape before COVID came along, is this move by many governments to either introduce, strengthen, or reshape their social health insurance, but also on the private sector side, with economic development, the growth of private insurance. And with that will become a maturity and a strengthening of purchasers of healthcare. And this presents opportunity for the private sector. But again, and as I will allude to, there may need to be new types of business models and new type of thinking from the private sector to get the most of the benefits and the opportunities that are out there. So just quickly, we still have the changing population. So we have an elderly population that's growing in most markets, albeit at a different level. Linked to that, the changing disease profile. So most countries were moving towards a heavier burden of NCDs. And where we were 10 years ago compared to where we were today, the NCD burden has increased in probably all countries. Some countries, unfortunately, and it's Africa quite often, has the double whammy, where they're still addressing the communicable disease, but they're getting hit with this wave of non-communicable disease. We also have the impact of COVID. Now, the impact of COVID is varied per country. It's dependent on lockdown. It's dependent on government policy towards the private sector. So we're seeing various trends, and we envisage that hopefully by the end of 2021 into 2022, things will start to balance back out to similar to what they were in 2019. But I don't think we're ever going to go back to the pre-COVID days. What COVID-19 has also done, in addition to the demand being placed on these health services for COVID-19 services, it has also created a backlog in some countries in terms of access for non-communicable diseases. Now, I don't have any research on this, but my guess is if we were to do research at the end of 2021, we're going to probably find the backlog on NCDs is quite large compared to what it was in 2019 because people haven't been able to access these services. So we have this wave of demand coming where most countries in emerging markets are just not set up currently for effective, broad, volume-based NCD type care. At the same time, there's a growing question, if I can call it that, on quality. So there's a growing realization that there's a need for better quality, and linked to that is the need for better outcomes. So we're spending more. People are questioning the quality. The healthcare professionals want to look for more quality, but at the same time, there is going to be a growing realization we need to start measuring the outcomes so we get more value for money within these systems. And we're definitely seeing this trend emerging in a number of countries outside of the developed world. There's also a need for increased access. So it doesn't mean we're just looking at tier 1 cities with large hospitals. We now need to figure out, how do we provide services in tier 2 cities, tier 3 cities? How can we move away from the hospital model? How can we implement out of hospital models and expanded primary care? Linked also to that is then the whole value agenda as well. So I think even during COVID times, it's been highlighted in a number of countries, questions or concerns have been raised about the pricing policies of some private providers. We do anticipate that going forward, there's going to be a bigger focus by insurers and or maybe regulatory authorities on some pricing. So the market is going to start to change. And as I said earlier, this trend was coming out pre-COVID, but we anticipate it to move forward post-COVID. And we also see the demand driver on medical tourism. I'm not going to talk to that now because we will be discussing it as part of the conversation. But medical tourism takes two key parts. There's inward and there's outward. So we're going to see a need to build models that stop the outward flow of medical tourism, but equally there is still going to be the demand for very specialist care for that managing. How do we manage that inward flow into like for example in India, where there has been this inward flow of medical tourism. So it's a topical conversation. So just quickly, the private sector can fill the gap. That's absolutely assured. The private sector, though, may need to start to think differently. It may need to evolve away from the standalone hospital models. It may need to look at a system type of approach. It may need to embrace primary care, definitely digital health, and I'll talk about that in a second, and out of hospital type services. So we are going to see a shift away and the need for expanded private sector thinking where they can serve directly the private sector in terms of the insured population, but also equally the ability to work with government. So we are going to see an increased opportunity for the private sector with the right business models to engage with government in some form of contractual service, either directly through social health insurance or maybe some form of reshaped public-private partnership. Digital health is changing the face of healthcare. We've had this light bulb moment with telehealth, but digital health has been around for many, many years. But I think now it's more conducive and there's more appetite to adopt and accept digital health. And it's important that the private sector is able to do that, embed it within its system so it doesn't stand outside as a silo, because that's going to help coordinate and manage care going forward. The supply gap could also be a demand issue on the healthcare professionals. It's a big problem. We're not going to fix the healthcare professional problem in the next 30 years. We're not training enough. And we also have, unfortunately, the developed world is still taking health professionals out of the emerging world. It's a major problem that needs a lot of attention. As I've said already, the new business models will come with an alternative pricing. So we envisage a move away from fee-for-service in many, many markets, and volume-based contracting, capitation type models, a new way of providing private sector services. And we're already seeing that. This isn't new. We are seeing a lot of providers evolving and developing their models. And then finally, the data analytics is we have a big problem in health where we have data sitting in multiple silos, and it doesn't always talk to each other. So again, we need providers to start analyzing the data, and we need the purchasers to start analyzing the data, and ideally working together to figure out, what's the best way to address certain diseases, population needs, and maybe perhaps even share risk in these new purchasing and provider arrangements. So I'll stop there. I've given you a very quick insight into how we see the world evolving over the next 10 years in emerging markets from a health services perspective. But I can't emphasize enough, the demand and supply gap is so big that the private sector can step up and step in and actively contribute to addressing these issues. But it is going to require a new way of thinking. Thank you very much. Next slide. Okay, well, I'll just say thank you and hand back to Lee. Okay, thanks.
So thank you very much for that, Charles. That was quite the overview. I'm not quite sure we'll have enough time to pick that all apart in the remaining 34 minutes, but we'll try. I wanted to ask sort of a two-part question, and I'll start with you, Max. It's basically, I wanted to invite you to comment on Charles' presentation, if there's anything you thought you might want to comment on or add. And I also wanted to pose the question just to see your opinion on exactly what you think the opportunity is for the private sector investing in healthcare in emerging markets moving forward.
Well, let me start by saying that it was so a comprehensive presentation that it's going to be difficult to add on. I think that what I can say from my side is yes, there is an opportunity, and the reason is clear. So Evercare exists because there is a huge opportunity there. And in terms of partnership, in terms of helping the countries in developing on the healthcare side, we can take as an example what has just happened or has been happening with COVID. We have been clearly part of the solution of the problem. And this thanks to the model, the governance, the flexibility, the agility, and the capabilities that we were ready to offer to each of the countries where we operate. But interesting enough, I don't know if everyone is aware, but at the beginning, we have been, we got the clear message that we should have stayed far from taking part of this battle. The first few months in all the countries, the authorities said private hospitals will stay and private groups will stay out. We as Evercare, as an impact company, we wanted to take part of this, and we insisted. And fortunately, after 2 months, in all these countries, they realized that they couldn't do it without our help, and we entered the field, and we have given a huge contribution. So this is one of the examples where you can't make it without our support and our help. But as Charles has pointed, is complex. It's not only about, this is an easy example, but it's a complex conversation. We need to talk about the kind of support or partnership that we can have with the public healthcare systems and with the other private groups. But definitely, to answer in a nutshell your question, it's a huge opportunity, and it's demonstrated that it's an opportunity for everyone, especially for the patients. Back to you.
Thank you. Thank you for your comments, Max. Leandro, I wanted to pose the same question to you about sort of any comments on Charles and what you think the opportunity is moving forward.
I think that he picked on a lot of things that we also see in our geographies, particularly around, and we only invest in Africa and South Asia, so our emerging market lens is more focused, and it's very different from Latin America, for example. But in the case of Africa and South Asia, when you look at the population, 80 to 90% of this population lives under $8 a day. So when we talk about private healthcare and the notion of quality, because private healthcare has a quality element that is costly, right? So you cannot compromise on the quality. If you don't have any of these mechanisms from subsidized health insurance of some way, there is a vast part of the population that will never be able to access this private healthcare. So for me, that becomes the key thing over the next 5-7 years. And I think that, if you're a government today, either if you're an elected government and you need to go for a new election or non-elected, healthcare has become at the center of the debate, as it was not before the pandemic. So the only way, when you look at the budgets of these countries, almost across emerging markets, fiscal surpluses became deficits. There is a debt crisis around the world as well. So the only way is with the private sector. So there has to be that way of creating subsidized health insurance systems. And some countries are doing it. Morocco is doing it. South Africa is trying to do it. Egypt, India has a state system. Without that, then we're talking about a very tiny population that could access this. So for me, that is the key of the next few years. If we don't fix that, I don't think the opportunity is more in theory than in reality.
And that's in particular in social health insurance, or is that generally in access to insurance as well?
Well, I think that, you've seen some creative products like Hospicash, in which there's not even insurance, so, people contribute something per month, and then if they are a night in the hospital, they get paid, no question asked. So
a subscription model.
A kind of a subscription model, but you need to think that, again, in a lot of these countries, the bulk of the population make very little money, so having the out-of-pocket to pay an insurance product that maybe you use, maybe you don't, that's why you have a lot of churn in those business models and fraud as well. So it will need to be something in which you provide benefits like an ecosystem, and some of the people are doing it, right? I mean, they try to provide an ecosystem in which it's not only the insurance part, but there is all the well-being and benefits, and that I think it has some legs, and I'm very hopeful that business models will emerge like that.
Thank you. So, it's an interesting question. So, Max, you have in particular, you've got a business model which is seeming more popular in the sort of networked approach. And so, what are your thoughts on how the business model is changing moving forward, and what are some of the things that Evercare is doing to capitalize on that opportunity?
Yeah. So I going back to the introduction made by Charles, I think I would like to stress the importance of going beyond the hospital system as it is. And we are fully committed to bring quality health care closer to patients in countries where mobility is an issue. And this is one of the reasons why, for example, in Africa, we open a number of, quite a big number, 16 clinics to cover more, not only the city where we are, where we have the hospitals, but also the neighborhood. This is a quite an interesting model that we are going to replicate in other countries. Additionally, we mentioned also the telehealth. This is, I guess that we will talk later more about telehealth, but finding the way to serve patients more remotely, more efficiently, is one of the things that we are exploring. We have been exploring. There is some success there, but there is a lot to do. Because, again, for us as Evercare, we have clear what is our target in order to patients that we want to serve and we want to reach, to be aligned with our impact purpose. But we're talking about 6 million. Yeah? This is the target of people. I truly understand. I understand what Leandro was saying before. When the scope becomes the entire emerging market of 1 billion people, probably the model or the business model has to be facilitated by bigger things, like giving access to insurance to patients and so on. Our business model today is basically hospitals. And we have general hospitals, we have clinics. We believe that we need to find a way to bring health closer to patients rather than the other way around. And we have been doing that. We recently announced our intention to further expand step by step in many other countries, and more probably this is the way. The way is focusing on bringing healthcare to patients instead of only attracting patients to hospitals.
And you're doing that through opening up hospitals and networks close to them, investing in primary care more? Is that the sort of the method?
Yes, primary care. So clinic, they are not really close to the hospital, but can take care of further people who live further, and eventually refer for secondary or tertiary care to our hospitals. But also the health part, the home care is something that we're really interested in not only exploring, investing in and moving forward. We're already there.
Okay, thank you. Charles, this is one of the things that we've spoken about in the past before is, I mean, do you see any groups that are starting to sort of mass consolidate across certain markets, that are starting to build network practices? Does this look like something which is the model that people will be moving forward into?
Yeah, we are beginning to, excuse me, we are beginning to see it. There's a couple of examples in East Africa, in Kenya. So you've got the Aga Khan group that has its hospitals, but it also has a clinic network. You've also got, some of the investments Evercare have as well in Kenya. They go beyond just the tier 1 locations. In South America, we do have a focus on South America, and also there are some good examples coming out of South America. Yes, the maturity level is a bit higher in South America, but we are seeing models that are these verticalized models, for example, coming out of Brazil, which are an integration of services and insurance. A move away from just the hospitals and the implementation of sort of these outpatient models and integrated with diagnostics. We're seeing a couple of examples in Asia as well. So there definitely seems to be a trend happening in terms of how do we move the silo of provision and how do we coordinate better. And again, an example I know well in Georgia, the country, not the state. There's a good example there of the Georgia Healthcare Group. It contracts heavily with government because that's how the system works. But they provide hospital services, but then they have a whole network now of clinics and diagnostic services, and they coordinate and they manage the population through the healthcare system. So I think there's a system thinking that's beginning to be seen in a number of countries, and there's going to be good lessons to be shared with others. Thank you.
Thanks, Charles. And Leandro, you've looked into home care, in particular in Egypt, right? There's some examples that you've mentioned of new types of services which have emerged over the past couple of years. Do you want to sort of?
Yeah, no, I think that is starting to change. We have an investment in diagnostics in Egypt, and even IDH that is public, that is our competitor, is showing 20% of now the diagnostic done in home services, right? So, and when you look at year on year, there is a big jump, more than, in percentage terms, it's even ridiculous, right? So I think that as in other businesses, when they say what is the main driver of technological change, has been the pandemic, right? So I think that changed the way, for example, in diagnostics, more things are doing home, and I think that's here to stay. Now, I think that where I still see that we have the big opportunity is and it goes back to the data. We have a lot of data on those patients that we are not using effectively. We're beginning to think about how to use it effectively. So I think it becomes is everything all together as we realize that serving those patients that we cannot reach out, but we may have data from previous interactions, what we can do in order to manage the health better, right? So all that discussion is now happening. And I think that for the markets in which we invest, it may be, in some cases, the only way forward. There will not be, in tier 2 and tier 3 cities, building, a 150 or 200 bed tertiary hospital will not be possible. You will need to build something more like Max is saying, maybe primary clinics with more technology. You can do more at the primary center, and then link it with that hub and spoke system. So that is coming, and you're seeing groups doing it, and combined with more home services.
Okay. Before I move on, I just wanted to remind everybody in the room and also online, if anybody has any questions, you can add them in the app, but also I'll open it up to the floor in a couple of minutes. So if anybody has any particular questions, I'll look around the room and note them, and I'll call upon you shortly. I mean, that's a good segue, so thank you for that, Leandro. So I think technology is obviously a huge, it's not just digital health, it's not just telehealth, it's technology generally, and everybody, we've got a whole day dedicated to it tomorrow about digital transformation. I was curious, Max, in terms of Evercare and how you're investing in digital. I mean, what is your focus? What are you doing across the group? And how has that been sort of spurred on over the last year or so?
As you can imagine, we had this pandemic represented a huge opportunity to boost all the programs that we started even before with the telemedicine, teleconsultation. But what we see as an opportunity is exactly what Leandro was mentioning. More we think about reaching more patients with remote clinics, and more we think that technology can help in referring less and less patients to the hospitals by taking care of these patients remotely from the hospital, but when they are in our clinics. We are also thinking about very innovative way of delivering drugs, medicines, even you would argue fancy ways like drones in very remote areas. And but the key point, being Evercare and an impact-driven company, is that every time we have these intuitions and these ideas, our main point is how we work on the price point, how we give access to this quality and this innovation to everyone, not only to the richest. And this makes the exercise a little bit more difficult, but not impossible, especially when you are able to partner with the right partners that can help in bringing this cost down. So ideally, it's all about telemedicine, teleconsultation, but in my opinion, more about really giving and empowering these primary sites and being fully connected with the main hub, or in some cases with also specialists in other countries. We were thinking about having a command and control for some of the specialties based in India and take care of all South Asia when it comes to serving patients that live remotely and maybe they don't have access to our hospitals, but they could have one day access to a clinic. So this is the way we are looking at it. There is a huge intention to make Evercare as one of the most innovative company in the emerging market, and we are very well supported by our investors, and we're getting there step by step. Thanks.
Okay, thank you. I mean, so there's obviously a lot of challenges with adoption in terms of that. I mean, Charles, you look at a global perspective. So what are some of the main challenges that are still, other than price point and reimbursement, with increasing access to digital services?
Yeah, look, I mean, I think it's very clear that we fully understand that if you implement digital health correctly, it benefits the patients, it benefits the professionals, and it benefits the sort of the payers as well. But, and this is the big but, is it requires careful planning, it requires careful selection, and it also requires a systems thinking as well. And what do you want digital health to do? What problem are you trying to fix? And there is a concern that digital health could get carried away with hype. It could get set up outside of the main systems and it won't necessarily integrate. And so we need to look at digital health and saying, okay, how do we integrate it? How do we build systems around it? And then also, how do we use the data that it produces as well? And I think that's one of the major challenges. And I think if we look back, mistakes have been made in developed countries and developing countries in their selection of electronic health records and everything that goes with it. Big costly mistakes have been made. So again, I think we have a massive opportunity with digital health, but it needs careful planning. And as I've said, this system thinking. We've also got issues around privacy, data privacy. Rules are changing all the time. So, for example, in Ecuador, they've just adopted the same EU rules for data privacy. So that brings a whole load of issues with it. And I don't think we're fully on top of the data issues and the privacy issues. And I think generally regulation runs behind the innovation that we see in the healthcare sector. So again, we need to be also mindful of that as well. And just one last comment. I mean, our venture capital team are the team that looks at a lot of this early stage digital health. And one of the challenges linked back to my earlier points is the sustainability of the business models, the growth beyond that pilot phase is where's that growth coming? Because it's becoming a really competitive market as well. Lots of people claiming they can do exactly the same thing. So we also have to be mindful of that from an investor perspective. Thank you.
If I may add to something that he said around also, because when we think about the telehealth or you know all these health or this technology, we think about between the patient and the provider. But there is, to what Charles was saying about the productivity that can be gained from the use of data, you know, call it in the B2B part. For example, in diagnostics, just take any of the GE, Philips, Siemens now, and you get the new diagnostic machines, MRIs, etc. They come with such powerful data analytic engines in order to direct the radiologist to where you need, right, to identify the tumor and discarding, you know, the cases that are, you know, normal, right? So for the same machine that you have installed or the same capacity, you know, you see, you know, across our markets, such a, you know, different productivity, you know, sometimes because they're even broken, the machines, and they don't have proper service. But even you can be an MRI with 7 MRIs a day and in another place 30, right? And the more technology and data is used to direct the radiologist to the right point, there you can think about the savings you can make. So that is another use of data that is happening right now that allows for the same amount of supply that you have to churn it into you know, a more productive way. So that's the other thing that I think it's remarkable. It's always been there, but somehow in the last year is accelerating.
And so who's the driving force behind that? Is that sort of the OEM manufacturers? Is that is it the private sector? Who is it? I think
it's the reality that, you know, there is when you see the imbalance between demand and supply, we're going back to the slides at the beginning, right? So there is a lot of supply to catch up here in order with the demands of the population. So and a lot of the equipment that you have in emerging markets today is not being used effectively.
Sure.
Right. So we're not talking about the you know, the Evercares of this world, but you look across, and it's dismal in some cases. You know, the low utilization. Sometimes it's because of lack of clinicians, and we're going to talk about that. But sometimes it's about the pure not using the data in the right way.
Okay. I mean, there's a good point where I think we should move on in a second to talk about labour shortages and the dynamics there. But I wanted to open up to the floor to see if anybody has some questions that they're itching to ask. Louis.
Thank you. I think it's a question probably for you, Charles.
Do you want to, because Charles is remote, do you just wait for the microphone for a second? It's coming, sorry.
Thank you very much. Is this on? Hello?
Can you hear Charles? No.
Charles, can you hear me?
No, it's still too quiet. I don't know if the mic's on.
I think it's just come on. Thank you. Charles, I think it's a question for you. Just firstly, I think to declare my interest, my name's Louis Shakunovsky. I'm the chairman of Global Dental. It's the largest and organically grown dental group in India. We've got about 350 clinics plus a number of other elements to our platform, a lot of it digitally and tech-driven. So my question is, what's your view of investment in India in the dental health area?
Okay. Thank you very much. Look, it's an area we haven't looked at India from an IFC perspective, so I can only give you my sort of view. We have invested in dental in other areas. I mean, as with other specialty services, the gap is probably bigger in some countries. So I do believe there is an opportunity. I mean, the key thing with some of the specialist services is, for example, dental or ophthalmology or those types of services, who pays and people's ability to pay, because even some of the insurance in its infancy doesn't always cover. So the key thing for looking at in sort of emerging markets is the business model, and is it able to offer services at a price that can stretch across multiple income groups. So that would be and that's a key thing we often look at when we're looking at India, just because of the complexity of the market. We've definitely seen in other markets a lot of interest around investing in dental care. It's not an area we of IFC have done a lot in. We have got 1 or 2 investments else, but not in India. But that's sort of my immediate response. Hopefully that answers your question. Thanks.
Thanks. That's very interesting. It's very helpful.
I mean, Leandro, did you have anything to add? You invest in South Asia in outpatient specialty services. Anything?
But we haven't done dentistry, so I wouldn't know. I wouldn't say anything different, so
Okay.
I prefer to pass.
Are there any other questions in the room at the time being? I've got one online, but I'll come back to that at the end if we've got a second. So I wanted to move on because it's a huge issue. It's a huge issue across, ask anybody in the room what their top 3 issues are, and they talk about labour shortages, access to people. Leandro, I'll start with you and just thinking about this from your perspective. And then I think, Max, I'll talk to you as sort of the investor versus the operator and how that impacts you. So when you're looking at businesses, I mean, how much of an issue is it? How much of a hamstring is it for you to be able to invest in businesses when there's a lack of labour generally?
It's probably one of the top 3 questions that, and in some countries is very difficult, more than others, right? So I would need to go into, particular countries. So now Nigeria is a big problem, for example, when you see and you get excited about the size of the population, that what you could do there, but then you don't have the basic talent. I think in some cases, Morocco is better supplied. Egypt has an issue with the Gulf, in which they pay 4 or 5 times what they pay a nurse in Dubai, what they pay in Cairo. So, there is a constant flow of people that way. I was last week in Dubai talking to one of the biggest operators, and 10% of their staff there is Egyptian. So I think that when, in our case, they were trying to build a big hospital platform in Egypt, what we found out is that the only way we could do this is that we had to create our own academy. So, just part of our investment went to create our own academy in which we're going to train our people, because, we couldn't rely on the public and private sector, the medical schools today. And I think that part of the answer is going to be that. I mean, you will need to look at investment models or propositions in which probably you will need to source your own talent and create your own talent. And that is, it's costly and takes a lot of time. But if you rely on these, fly in, fly out, models from doctors, etc., I think you put yourself in a very precarious proposition. And again, is something that in Africa, I mean, I come from Latin America, that was never an issue when I was investing there. And in some places in Africa is the top concern. In India, I would say there are several Indians, right? So tier 1 versus tier 2 and 3, they're complete different situations. So yeah, very much an issue, and you need to solve it probably by yourself.
So your training academy is set up specifically to train and recruit into that hospital, or is it more of a system? Yeah,
well, we were trying to go from multiply our number of beds by 5 in 7 years. And, when we started to add the number of nurses and clinicians, it was impossible. So we either, not that we're going to train everyone in-house, but we need to make sure, at least on the nursing staff, on the support staff, we have our own supply. tied to contracts. So tied to contracts, we will give you the education for free, and then you stay with us for a number of years, right? So just ways of thinking of how to make sure that you have some kind of stability in your workforce. Otherwise, your hospital will fail, if you don't have the right way to source that. Well, I'm sure Max, deals with this all the time.
Yeah, sure. Go ahead, Max. I'm sure you can comment directly. I mean, you deal with both of those issues day to day.
I can only echo Leandro. So by far one of the biggest challenges that we have is this one, and as Evercare we have been doing exactly the same. We have recently, 2 months ago, kicked off in Nairobi the Evercare Health Science College in partnership with an American university. And we aim to train as soon as possible at least 10,000 nurses, and not only nurses actually. The same, we have been doing the same in Bangladesh, and we have a sort of citizenry academy in Pakistan. Additionally, we have implemented, and we are implementing every time we open a new hospital, we we use our Indian organization where talents are available to send in a 2 years assignment doctors and consultants and nurses with a clear mandate of creating a second layer of registers and new doctors and new nurses ready to take over in maximum 2 years. This is the model. It's very expensive. We don't mind. It's expensive because you train 10,000 nurses, but probably only 100 or 200 or 300 will remain with us. The others, as Leandro said, will fly to other countries or in other places. But again, this is part of us being an impact company. We do this because it's part of the way we are having a social impact in Africa and in South Asia. So very glad to make this effort, an expensive effort, but yes, this is one of the things that in a way or another we have to manage if we really want to create quality, sustainable healthcare in these countries.
And so those colleges, you've set those up off your own back, or is that in partnership with the government? Because one of the things I'm wondering about is whether, obviously, the need for increased access to care is how receptive the governments are at taking away some of those, potentially ridiculous labour blockages that they have.
I can make you and all our guests laugh a bit, because the only time we try to partner with the local government, what happened is that they really accepted to start this nurse academy in Bangladesh, and after 1 year, basically, so they gave us the building and the institute, and we basically funded all the rest. After 12 months, they came back to us and they say, now you buy at this price the building if you want to continue your academy. So this is just to reinforce the fact that we're not yet there. So we try to partner with them, but we will continue to push in this corner. But in the meantime, we rather prefer to go our own way, as we are doing in Nairobi and in Pakistan. And I will let you know maybe next year if we have made any progress with the health authorities in Bangladesh in dealing with that issue.
That sounds good. You can come back next June for the next edition and tell us all about it. Leandro, you have the same. You have the same sort of opinion. In Egypt, it's particularly difficult to set up a medical school, right? You're a training academy. There's a lot of hurdles to jump over.
Well, I think that, if you look across Africa, still survive a lot of restrictions for the capital flow into these sectors, right? So it may be, in some cases that only a radiologist can own a radiology practice in some countries, or that in order to buy a stake in a university, you need a presidential decree, right? So, or people from country A cannot, I mean, many doctors from one country cannot validate their credentials in the country next door, right? Or they can in theory, but it never happens, right? So if you remove these things, you know, there's so much that can be done without a penny, right? Just cutting the red tape around, not the standards in terms of, you know, quality, quite the contrary, but allowing the private sector to participate. And I think that is still, in some countries, for, I presume, vested interest or some other political agendas, is still something that needs to be done.
Well, that's a good place to end. Unfortunately, we've run out of time. I think we could have kept talking for another hour or two. But thank you very much, Leandro and Charles and Max. Thank you both for joining us. Thank you.